Dr. Taştan, thank you very much for being with us.
Thank you.
Are you having a good time in the city in Barcelona?
Yes, I have enough time. Actually, I have been here more than 10 years ago, but of course I forgot most of the places. And then we have chance to visit some of them again. Thank you.
And also work a bit and do your lectures and be in the Congress. Tell me, first of all, why did you develop an interest on noses and rhinoplasty?
When I start ENT residency, so I just realized that two different areas are too much. I mean, ear, nose, throat, they are totally different. And then this is a simple philosophy. I always believe that it's better to be specialized in one thing. And then when I think about nose, there are many variables, and many surgeons trying to do something better, but still they are not satisfied. Then that idea was attracted me, and then I just tried to be specialized only in one field. Maybe more than 20 years I'm doing only functional and aesthetic nasal surgery. This is true also for the life. I mean, so let's say when you go to somewhere for a holiday, if you want to eat something, I choose a restaurant that is only doing that thing, not all of the things. This is similar.
Exactly. You were talking about functional surgery too. In many ways, what you do changes the life of people, not just in the beauty point, from the beauty point of view, but from the functional point of view. I mean, not being able to breathe properly is or can be a problem, a health problem, can't it?
This detail is, of course, when it's about aesthetics, it pays more attention. But nose is an organ, like an eye, like an ear. So it must be functionally well enough. So it's really important. It has many functions, probably, as you know. I mean, filtering the air, humidifying it, and changing its temperature, etc., etc. So this is an organ. So as a human being, we are trying to add some modifications to feel ourselves better. I mean, aesthetic is not a natural thing we are trying to change, but maybe in 100 years, I mean, so there is such an expectation, and if we are trying to change the shape, I mean aesthetics, then at one hand function, at the other hand aesthetics, and we cannot decrease the function to have a better aesthetics. I mean. So when we are planning to do something, it must be first as an organ good enough, then accordingly shape the nose, say according to the facial features, etc.
Mm-hmm. What's changed in your area the last 15, 20 years? Because I mean the area is growing really, really fast. There's lots of changes. You can tell a nose that was being operated like 30 years ago from now that's been operated from one that's been operated on now, can't you? Because there's been lots of changes.
Yes, you're right. So actually, this answer depends on which window we are looking from. So let's say at one point of view, actually not too much changes, and there is not too much changes because we are removing something, we are adding something, etc. But during the last maybe 15 or 20 years. More specialized surgeons, the ratio increased, and also patient expectation increased. So about the aesthetics in the past, let's say surgeons have to do like that. I mean, they had to do like that because they had to do many different surgeries and also, let's say, nasal surgery. So more or less there were some, basically it's about reduction. I mean, making something smaller, something more curved, etc. But in time, patient expectation and surgeons, let's say specialization a little bit changed. And during the last 10 or 20 years, it's more popular to do, to provide more natural results. I mean, of course, functionally well, but aesthetically it must fit to the facial features. It must be seen natural. I mean, as if it is not operated. If you see a nose and then you are thinking that, yes, she is operated, but really nice result. It's not a good result because you already realized it. So basically, the change is about aesthetic perception, patient's expectation and aesthetic perception. And the other detail about the techniques. Actually, we are trying to, many colleagues may be trying to mention that some instruments change, etc. But actually, there is not too much change. Some electrical instruments we are using, but it's also another point of discussion, because let's say there are advantages of such instruments, there are disadvantages of such instruments. If you focus only the advantages of an instrument or of a technique, then the result will be different. But all of the techniques and instruments has advantages and disadvantages. So because of that, we all own many things to the previous surgeons. I mean, in the past, of course, we didn't meet them, but we read their books, we did read their articles, and this is a common knowledge, and we are using that common knowledge. There is a saying that we are dwarfs on the shoulders of the giants.
Exactly.
So when I see that a surgeon trying to show himself as the best, then I think that he or she couldn't realize the philosophy of this job, I think. So most of the things already we all own to the previous surgeons in the past. So we are just adding some more details, just make it more natural and functionally better. That's it.
You've developed lots of three techniques which are different. What's the technique that you developed that makes you more proud?
Yes. So I had a chance to develop 3 different techniques. 2 of them about function, let's say septal perforation repair or nasal valve surgery. But the most popular one is about rib cartilage carving. So I mean, rib cartilage already has been using more than 60 years. But there are some problems, but this may be due to technique itself, maybe due to misunderstanding of the surgeon, the technique, because it's all about equilibrium of forces affecting the rib cartilage. So at the operating table, you reconstruct a good skeleton, but it is straight. But at postoperative period, it tends to warp, bend. So it's a problem for us. So when I focus to think about it, you can carve the rib cartilage in 3 different planes. Of course, this is a medical terminology. I mean, axial, coronal, and sagittal plane, let's say. So we need straight grafts. So when we use the cross section of the rib, then the rib tends to preserve its shape. It means think a slice of cartilage, let's say 1 millimeter in thickness. One surface of the cell groups are in continuous at the other surface, so they are neutralizing each other. Also, rib cartilage has an interesting structure. Its center is different, periphery is different. So the central and peripheral cell groups are also in equilibrium. So it really preserves its straight form because of these equilibrium of forces. So actually, the rib was already there. I didn't do anything actually. I just think about it and cut it like that. And the explanation is this. So some of my friends asking me, why didn't you call it Taştan's method, etc. This is not Taştan's method. This is rib's behavior, and that was already there.
But you had to think of it. You had to, I mean, you had to put it into the patient. You have to see that it was working. I mean, it's a lot of process. I mean, there's also lots of value in that. You also specialize in secondary rhinoplasty. Sometimes it just happens because the patient doesn't like the result. But in many cases, it happens because some surgeons don't do their job properly, or they make mistakes, or things happen that maybe we couldn't see before, no? So I think it's another complication to operate on a nose that has already been operated on. What's the added complication on that?
So of course, secondary rhinoplasty is totally different than primary, because primary everything is untouched. You are touching first time. You can achieve the desired result because everything is fresh, everything is new. So But the revision cases, of course, in rhinoplasty, really, there are many variables. And if the surgeon, there are two different points, of course, patient expectation and the actual result. So it's better to focus basically to the actual results. So as a surgeon, we have to aware about our limits. Let's say when we are younger, when we don't have enough experience, it's better to choose the patients according to our experience, and then first learn the basic things you have to learn. There are many good surgeons, they can follow them. There are many meetings, etc., courses. So first, as a surgeon, we have to know our limits. So accordingly, we have to touch the patient.
Yeah.
Also, after some time, also our mind may mislead us. After doing some, let's say, few surgeries, we are thinking that now I'm already experienced, now I can do more, let's say, difficult ones, etc. Then the problems start, because it's better to go step by step as a surgeon. The other detail is, of course, there are many surgeons and many different experience levels, but all of us have egos, and we are thinking that we are doing the best. When we focus, or we don't aware this idea at subconscious level, when we start that we are already